Right. Hello, everybody. Yes, welcome. Welcome to today's webinar, and thank you, Doctors Data, for having me and collaborating in this effort to bring functional medicine education. I've been a functional medicine educator for quite a while now, and when I do mentorships and when I teach, often one of the most important questions that I get, and often questions that I get, is what kind of labs do you run? How do you treat complex cases? How do you sort out all the different labs that are available, all the different treatments that are available as we are in our practices day to day? We're seeing more and more complex cases, cases where people present with multiple systems out of balance and multiple symptoms. So how do we navigate through the myriad of symptoms and different treatment options out there, all while making this affordable for patients, understandable and doable, so as well as effective. So that's what I'll do today is present how I go through my complex cases from kind of start to finish, and I kind of specialize in complex cases since I've been doing this for so long. I kind of have the reputation of being able to go through some pretty tricky cases, and I often get those cases that other practitioners either don't feel comfortable treating, or they reach a point where they don't feel like they can go any further. So we're going to talk about a lot of topics today, not just autoimmune, but of course, we're going to wrap this into an autoimmune context because we're seeing so much of that, especially post-COVID. But this is our modern era of health and disease is increase in autoimmune and immune dysfunction. So let's begin. Let's jump right in. I am going to cover the best labs to run for getting to the core of complex cases. How do we resolve autoimmune quickly? This doesn't have to take years and years to resolve. It can be resolved within a few months, really, in many cases, in most cases. We'll talk about the gut mitochondrial axis, the neuroendocrine health, how that all ties into autoimmune, resolving mold and other environmental sensitivities or infections. I'll talk about some of my nutritional protocols that I use. That's always a popular question is, what this information is great, but what do you actually do? How do you prescribe this? And, what does this really mean for my patients? What can I use, tomorrow for my patients? And I'll talk about, furthering your functional medicine education through my nutritional pathology and functional medicine certification course, which has been taken by thousands of doctors, and a mentorship course that I do as well. So autoimmune disease, this is what we see. And when in practice, I've been practicing almost 20 years, and I can track throughout my career some books and articles that really bring everything together, bring ideas together, right? And you can probably do that in your career too. Why you even got into this career, books that got me into this, and one of the galvanizing concepts and theories is the autoimmune triad. I read this by Alessio Fasano, probably 10 years ago, how he studied celiac disease, and he realized that through celiac disease and zonulin and leaky gut, how almost all autoimmune disease is essentially the same autoimmune immune dysregulation. And so thinking of all autoimmune disease in this autoimmune triad is really, really helpful. It really helps you both understand autoimmune, explain autoimmune to your patient, as well as develop a comprehensive and effective treatment plan, because all three of these things need to be addressed. So the first one is the top here, leaky gut. Leaky gut is essential to have. It's a prerequisite to have for all autoimmune disease, right? We get that intestinal barrier dysfunction. We get the multifocal dysbiosis, not just dysbiosis in the gut, but dysbiosis in the genitourinary tract, in the lungs, sinuses, respiratory tract, inflammation that happens throughout the body, not just in the gut, through activation of interleukins and cytokines, and of course, for some, the release of zonulin. We also have that genetic piece where that comes together, where you have to have that HLA haplotype, that background. There's often methylation issues that allow that autoimmune gene to be read. And so that's your methylation connection into autoimmune. Inflammatory genes, people that have more tumor necrosis factor alpha genes, interleukin genes, they tend to be more susceptible to autoimmune. Redox genes as well, GSTP, those that with low glutathione, whether genetically or environmentally or both, that comes into play into developing autoimmune disease. So that epigenetic as well as genetic factor needs to be addressed in all autoimmune disease. You can't get away from it. And then finally, this environmental trigger, that could be stress, which is a very common cause of autoimmune disease. And we don't want to say cause because it's not the only one cause, but it's often the straw or the brick on the camel's back that finally breaks the camel's back, breaks the immune system into full-blown dysfunction. And then some infections can do that as well. Nutrient or diet deficiency, toxins, heavy metals, all of those end up playing a role in your autoimmune cases. So our job as practitioners is to be the detective, right? And sleuth out what are all the factors in this individual. Each one of these triads could be 20, 30 different things to look at. So how do we do that? I like to say we test, we don't guess in functional medicine. Test, don't guess. If we have the test, then that ultimately saves money for the patient. It saves time for the patient, because then you know exactly what treatments to do and to apply for that patient. So causes and drivers, whether they're primary or secondary. Again, this genetic predisposition, leaky gut, all these environmental triggers, these oftentimes the infections that I see, Epstein-Barr, herpes, could be Borrelia, H. pylori, Candida, toxoplasmosis, cytomegalovirus, all of these play a role into your background, into the patient's, infectious and inflammatory milieu. So lifestyle, stress, the toxic exposure, and this is lifetime exposure. This isn't just acute exposure. So, and we know from studies, environmental factors in autoimmune disease and the role in things like multiple sclerosis. So we've got the Western diet and how that affects the microbiome, and dysbiosis and your genetic predisposition plus your environmental factors. So this is a good diagram of how the autoimmune triad actually plays out in physiology. And you get that immune imbalance. You get an imbalance of T regulatory and T effector cells. The T effector cells, the inflammatory cells become overabundant, and the regulatory cells become decreased. So, and patients can be in this for years, sometimes decades before they come to see you or before they get a symptom. So it's not easy to address. It's somewhat simple, but it's not easy. And this is Alessio Fasano, one of his many studies talking about zonulin, its regulation of intestinal barrier function, and how that's the biological door, one of the biological doors to inflammation, autoimmunity, and even cancer. It's this leaky gut becomes absolutely imperative to treat. The dysbiosis and leaky gut is primary. And I think that gets missed, certainly gets missed in traditional Western medicine, as we know, but even in the functional medicine circles and in practice, it tends to be underestimated or undertreated. So this is a great study too, and he's done many, but zonulin is a finely tuned pathway. But when zonulin becomes upregulated, I like to think of zonulin as it's a rule-in test and not a rule-out test. And we're not taught, I think, laboratory medicine in a good way. And that's my passion, is laboratory medicine as it gets translated into practice. There's so much good data that we can have, but we need to understand what that data means and not just have these knee-jerk reactions to a high or a low test. We need to understand what each analyte is and where it comes from. So if zonulin is high, certainly that rules in leaky gut. But if zonulin is low, that doesn't rule out leaky gut. There's many different pathways of leaky gut, but zonulin is just one of them. It's a well-studied one, but it's not the only pathway to leaky gut. So just remember, you can have a normal zonulin, but still have leaky gut. But if you have a high zonulin, you definitely have a very active leaky gut or increased intestinal permeability. So running a zonulin test, again, it's a rule-in test, not a rule-out test by any means. So I mentioned earlier these seminal studies or books that we often read in our careers that really galvanize or even transform or change our direction in clinical practice and in our way of thinking. And this was one of them. This was back in 2011, but this is when all of this started to really flourish and really change the landscape of both clinical practice as well as research. So I remember reading this study. I was like, yes, this brings it all together. Leaky gut and diabetes. What is the link? And we're talking about not just type 2, but type 1 as well. And how these researchers out of the University of Copenhagen talked about and delineated and researched, well, if you have whether it's type 1 or type 2, what determines whether you get that is whether you have leaky gut or not. So type 1 diabetes, there's a 30% concordance rate among genetically identical individuals. So that tells you genetics play a role, right? Because within the population, it's 10%. So, but 30 to sometimes 40%, that's okay. There's a genetic component. But if it was just genetic, every single person with type 1 diabetes who had a twin, both of them would get it, right? So it's not just genetic. 60 to 70% is environmental. So, and what determines whether one twin gets it and the other doesn't is often whether that twin has leaky gut or not. And that's what these researchers found out. They did both retrospective as well as prospective studies and really kind of really laid it out definitively how that works. So it's the dysregulation of the intestinal barrier that causes the trigger of the autoimmune. So and as they go on via alterations in the intestinal permeability, infectious agents, dietary antigens, and we'll talk about measuring dietary antigens. It's really important. I just had a discussion with a nurse practitioner who was very, very, traditionally trained, right? I mean, we've all had our origins in traditional training. And she was saying, well, IgG food testing is really not proven to do anything. Well, it is. It's not an IgE allergy. So I think a lot of us were taught that, well, it's not really an allergy, so ignore it. But it's these dietary antigens that you measure, that if you're eating those and it's triggering IgG responses, what's driving autoimmune? These are IgG antibodies. So you are going to, these dietary antigens have proven to increase interleukins and cytokines within the body. So these food sensitivity tests, IgG, even IgA, can be very effective at reducing body burden of inflammatory chemicals. So, but these increased cytokines can not only damage the insulin receptors and cause type 2 type of diabetes, but it can trigger the damage in the islet cell antibody production as well. So both type 1 and type 2 have this autoimmune or leaky gut component. So reinforcing the intestinal barrier really does become the ground zero for autoimmune treatment. So, and in this study continues, a significantly increased lactulose mannitol ratio. And by the way, that's not a very sensitive test. It's very specific, but it's not a very sensitive test. If you do have elevated lactulose mannitol ratios, then you almost always have leaky gut. That is a very specific and accurate test, but it's not very sensitive. You can still have significant leaky gut, clinically significant leaky gut, without an LM ratio being increased. So if you want to really rule in leaky gut, you can do the lactulose mannitol test. However, I find that doing a food sensitivity test can also rule in leaky gut and intestinal permeability. So these pre-diabetic subjects had the greatest increase, suggesting that increased intestinal permeability precedes and is the main contributor to the onset of clinical diabetes. So that was like, hey, nobody at the time is really talking about diabetes, treating leaky gut for diabetes, both type 1 and type 2. So leaky gut is characterized by elevated CRP, interleukin 6, interleukin 12, 17, tumor necrosis factor alpha. Not all of these, and sometimes none of these, are elevated in leaky gut. But oftentimes you're going to see at least one or two of these being elevated in leaky gut. So that becomes another potential diagnostic criteria as well. And as we know, these cytokines decrease the function of insulin receptors, beta cells, and all the blood sugar handling mechanisms, leads to insulin resistance, diabetes, more inflammation, and other autoimmune disease as well. And the tricky thing about leaky gut is leaky gut tends to produce inflammation, which tends to produce more cytokines, which tends to produce more leaky gut. And so leaky gut is a very feed-forward type of physiological process. And just want to review this because it's really important as we treat it. I consult with many doctors and practitioners in functional medicine, and I still find, yes, everyone understands this, or a lot of people understand this mechanism, but it's the translation into clinical practice that I'm interested in, and I'm trying to get, and that I see lacking in some practitioners. So I want to emphasize again just how important this is. And then we'll talk about how we translate this into the testing that helps us confirm the diagnosis, as well as the treatments that are effective. And lipopolysaccharides, as we know, also lead to pro-inflammatory cytokines. This then leads to further intestinal inflammation by binding to toll-like receptors, which then triggers more inflammation. So it's just this feed-forward loop that keeps happening. Treating, whether it's type 1 or type 2, whether it's celiac, whether it's rheumatoid, whether it's lupus, whether it's seronegative autoimmune, this becomes really important. So that's what we want to look at is really addressing the leaky gut. So knowing that, I can go into the others too, and I will, but I'll do it in this case study context. The other pieces of the autoimmune triad. But I wanted to just set the stage for how important leaky gut really is. So we're going to go into methylation too, and how important that is, and some of the epigenetic factors, and we'll go into the autoimmune triggers, the environmental triggers as well. So let's jump right into this case study, Rachel. Rachel came to my office, and 38-year-old female complaining of weight gain, swelling in the body, not just the gut, but ankles, and her whole body just felt like it was swelling, which is another indicator of systemic inflammation. She had a fairly normal BMI. Of course, we know BMI is not that accurate, but she was still about 25 pounds overweight, which tells you that normal BMI is not, as we know, BMI is not a really good, accurate measure. So extreme fatigue. She was on a high dose of thyroid meds. I'll get into how high it was in a minute. And her TSH was undetectable, and yet she still had every symptom in the book of low thyroid. So elevated cholesterol, elevated MCV, elevated homocysteine. Those are all clinical laboratory indicators for hypothyroidism. So you can't just rely on thyroid numbers. We want to rely on the downstream effects of thyroid to measure whether there's really a thyroid issue going on. Mood swings, depression, anxiety, brain fog. Does this sound familiar? A lot of our patients complain of this. This is what we treat on a daily basis. She was also told, like so many people these days, that they have a sensitivity to mold. I have an opinion about that. I don't believe that we should blame everything on mold. Certainly some people do have it, and it is important to address, and it can be a game changer. But I've seen so many practitioners kind of just go to that if they don't know what else is going on. And we need better indicators. We need better better diagnostic criteria to really go after changing someone's, wreaking havoc on their whole lives to try to find the mold, and, everything from changing furniture, moving houses, renovating everything. And many patients end up doing that and not getting any better because this whole picture is not being addressed. She had constant belching, bloating, some constipation. That was really, getting to her. No one likes to walk around being constipated and bloated. You just don't feel, you never feel right if your gut isn't working properly. She was starting to get acne, rashes on her cheeks, back of her legs, low libido. She recently was diagnosed with uterine fibroids, which is, this estrogen imbalance. So she was, and she had been seeing at least 3 other functional medicine practitioners by the time she had come to see me. And many of them, I think, did more harm than good, which is another reason why my passion is teaching. So I think they fell into some functional medicine traps that in my training, in my education, I try to have my students and doctors really avoid. So she started seeing a functional medicine practitioner 5 years earlier for some gut-related symptoms. Labs showed just mildly decreased thyroid function. So her T3 was suboptimal. Her TSH was maybe around a 4. But they put her on very high doses of T3 and T4. I'm talking 50 micrograms of T3, which is 10 times more than the body actually produces in a day, and 150 micrograms of T4. She felt great at first. I mean, that's just putting jet fuel into a car with 4 flat tires. Yeah, you'll go down the road pretty fast for a while, but eventually those wheels are just going to come off. And she never really then felt the same since. And when she came to see me, she was still on 50 micrograms a day of T3 and 150 of T4. The human body, okay, not pig or cow, but the human body produces a T4 to T3 ratio of 12 to 1, 12 T4 to 1 T3. She was on 3 to 1 T4 to T3, and that's going to cause insulin receptor damage. There's a principle that we always should keep in mind when we're dealing with any hormone. I don't care what hormone it is. And those of you that have heard me speak before, you know what I'm about to say. And this is the downregulation and upregulation of of receptors as it relates to hormone levels. So if you have elevated thyroid, what's going to happen to the receptor? The receptor is going to downregulate. It's going to shut down. Same thing with progesterone, estrogen, testosterone, whatever it is. If you have supraphysiological amounts of a hormone running around in your blood, your body is going to down regulate that receptor. Essentially, you're creating a resistance to that hormone. And this, unfortunately, you can reference my last Doctor's Data webinar, which caused a little bit of a stir for some people, because I'm really about doing hormone replacement therapy, hormone restoration in a safer, in my opinion, safer, much more scientific way, where we don't just jump to replacement. We try to restore natural balance first, and we protect the receptors and we help the receptors function properly. So she was in a thyroid resistant state for sure. So, and what do you do with that? Most practitioners just keep upping the dose, upping the dose, upping the dose, hoping that they'll feel better, and then they're just making the problem worse. She was exposed to mold during treatment, during the previous 3 years or so. When a person is in a dysregulated autoimmune state, they're more likely to develop a sensitivity to mold. Sensitivity to mold is simply a symptom of another issue. It's not necessarily the mold's fault. And yes, you do have to remove the mold, but why are you going after the mold when it's really the body's response to the mold? You could have 10 people exposed to the same mold. 1 or 2 of them has severe reactions. The other 7 or 8 don't. What's the difference between those two, or between those 2 groups of people? It's the internal milieu that needs to be addressed and needs to be assessed and needs to be treated. So she took fluconazole for a month. And this is what I'm saying. Did she really need to take fluconazole? Maybe so, maybe not. I wasn't there at the time, but I found in almost 20 years of practice, very few times does someone really need that. She took fluconazole for a month, experienced many other health issues. She developed gallbladder stagnation, which is often what happens. Even taking cholestyramine or some other bile acid producing drug, she got gallbladder stagnation. She developed SIBO. She developed more mold sensitivity. She started to wean off her thyroid meds, but then everything exploded after another mold exposure. So this is when she came to my office, and so this is kind of the health history that you see. They've been around, they've done a lot of things, but what really has helped them and what hasn't. She does have some pertinent history findings. She drank alcohol for many years. Now she can't process any at all. So that tells you that her inflammatory milieu is probably driven by some of that alcohol. She wasn't an alcoholic by any means, but the research shows that there's really no safe level of alcohol. Don't shoot the messenger. I didn't come up with these studies, but I read them. I think it's fine to have a drink here and there, but the research is clear. There is a breast cancer research that showed even 1 or 2 drinks a week, as little as 1 or 2 drinks a week, still increase your risk for breast cancer and all-cause mortality. So yes, while I think it can be fine if you're healthy, if you're not healthy and you're drinking regularly, even 1 or 2 glasses of wine a day, you're just producing a ton of inflammation in your body. Sorry, don't come to my parties if you want to drink. No, it's fine to enjoy now and then, but again, it is inflammatory. Just knowing that it's inflammatory. She had ovarian cysts many years earlier, so a little bit of not necessarily PCOS, but as we'll see in the labs, definitely tended towards that direction. She had one child, which resulted in emergency C-section. She couldn't breastfeed for long. So all of this is telling you that, oh, there's been a lot of inflammatory issues for a while. She had an IUD and birth control for 10 years prior, and she never really gave her body time to clear that out. So one of my specialties is preconception planning, and I've been doing it for 15 years. And you need at least 6 months to kind of let your body get back. And many women just take the IUD out and then get pregnant within a month or two, and that is not going to give you optimal fetal outcomes in many cases. Busy, stressful life in general, that's something that absolutely has to be addressed. 6 to 8 hours of sleep, but some difficulty staying asleep regularly. She had to severely restrict her diet, and she couldn't reintroduce foods. That's another indicator of leaky gut that hasn't been resolved. And on a scale of 1 to 10, her overall quality of life rating was about a 3 or a 4. I don't know about you, but I don't want to go through life with a 3 or a 4. That's not a very good quality of life. So that's what we do, right? We help increase quality of life by getting to the real issues in people's physiology. She was on these medications. Another one that kind of look, low dose naltrexone can be helpful, but I find so many practitioners just going to that when they don't know what else to do. So there you go. She was put on low dose naltrexone. Did it help her? No. I find that about maybe 20 to 30% of people who are put on low dose naltrexone actually derive any benefit from that. It can be a game changer for those, 20%, but for the other 80, it's not doing them any good and potentially doing them a lot of harm. So she was on 125, sorry, I said 150, but she was on 25 micrograms morning and afternoon. So there you go. She was actually even more than a 3-to-1 ratio, or less than a 3-to-1 ratio. So she had a bunch of supplements that she was taking. I'm not familiar with some of these things. I'm familiar with what they are, but these aren't anything that I put her on. It doesn't seem to me to be a very well-developed treatment plan. What are we treating here? Okay, some gut support. Well, what is that? Is that fiber and super enzymes? Is that enough? Is that really treating the leaky gut? Is that really treating her issues? Obviously not. She's taking some trace mineral drops, some ashwagandha, okay, because she can't sleep, vitamin A, trace minerals, some DIM, okay, that's great, some zinc, some Chinese herbs that may or may not be helpful. I'm an acupuncturist, so I love Chinese herbs, but you really have to know what you're doing if you're going to mix Western nutraceuticals and Eastern Chinese medicine, because they can counteract each other in many ways. So she was taking some copper because she was diagnosed with a copper deficiency, some liver support. I mean, it seems like, all right, there's some things being addressed, but ultimately it was kind of just, throwing the kitchen sink at somebody and hoping that it sticks. And that is not functional medicine. Every supplement, every nutraceutical that I prescribe, we have either real clear, hard laboratory data or very clear clinical data to support that. So this is a test that she had right before she came to see me. This is similar to blood work that I do through LabCorp. So it was sufficient. I didn't need to redo it. Her glucose was a little bit elevated, so probably some insulin resistance. So her sodium serum was a little bit low at 139. As you know, these are not healthy ranges. These are not optimal ranges. Sodium serum has a lot to do with mineralocorticoids, with adrenal function. This does not really reflect dietary intake of sodium unless it's extreme one way or the other. Really, sodium is tightly controlled by the adrenals through mineralocorticoids. So it tends to become a good surrogate marker for adrenal function. And I find this to be very accurate in its surrogate marker. So I've written a blood manual, a blood test manual. You can go to my website, Dr. Brandon Lundell, Dr. Brandon Lundell, and you can go to my courses and education tab. And I've written what are healthy ranges, and these, it's very well researched. I've gone to blood chemistry courses where they say, oh, you just want to be within the first standard deviation, not the second. But that's not true, because as the whole population gets sicker, that whole curve shifts to the left or the right. So how do we come up with healthy ranges is often the question. Well, how we come up with healthy reference ranges and optimal reference ranges is the gold standard, which is to take a healthy population and measure their blood, which is what we've done and what some studies have done, and where we can derive healthy optimal levels. So taking people that we know are optimally healthy, because the definition of health in Western medicine is just a lack of diagnosed disease. And as we know, that most people walking around labeled healthy are extremely dysfunctional. So where do we get these people? Do we have to go to some remote island, that's very healthy? I mean, where do we find people that are actually optimally healthy? Well, it's the people who are thriving. It's the people who are exercising well. They have a lot of energy. They might be taking some supplements. Their relationships are healthy. They can go through the day without having to take a nap. Like they're expressing full optimal health, not just a lack of disease. Then we take those blood markers and say, well, that's where we want to be. But it's up to us as practitioners to do that, not the labs, because as every lab will tell you, doctors' data included, they kind of have to report population-based values, right? So the quintiles or whatever you get in any lab, including this, is really just a laboratory sample, and then they develop the bell curve, and that's the standard deviation. Labs are not able to develop their own optimal levels. That's up to us as clinicians. So that's why I wrote the lab manual. That's why I teach blood chemistry. I am teaching a blood chemistry course in a couple weeks, and I love blood chemistry. It is so important. There's so much information you can glean if you understand each analyte. And still, in functional medicine, no one's teaching blood chemistry with a focus on the physiology of each analyte. It's usually given like, well, if it's high, to put them on these supplements. If it's low, put them on these supplements. That's not really helpful in functional medicine. So we want to develop really good ways of analyzing each analyte and coming up with an accurate diagnosis. That's the key, coming up with an accurate diagnosis, a functional medicine diagnosis, not just skipping to the treatment plan because you went to a seminar and that's what they told you to do, right? So that's why you're here. That's why you attend these webinars. So the blood chemistry course, if you're interested, you can contact my office. It's in Kansas City in 2 weeks. So, and it's all new material. It's something I've never done before. So if you're interested in blood chemistry, come on out. I'd love to have you. So we have some other things too that are a little bit out of balance. Our AST and ALT are actually a little bit low, and that's often a B6 deficiency because they're B6 dependent enzyme. So we already have an idea that her adrenals may not be functioning well, and she's nutritionally deficient. Her rheumatoid factor, no one had ever tested this because she didn't have joint pain, but her rheumatoid factor was almost 50, okay? And no one had ever tested for that. Many people have rheumatoid or some kind of autoimmune that's expressed the rheumatoid factor, but they don't have rheumatoid arthritis per se, but it's clearly an autoimmune issue. And her white blood cells are low, which shows at 38, she shouldn't be having immunosenescence at this point. She's developing an immunosenescence too early. Chronic infection may be an issue. A nutritional deficiency may be an issue as well. So her C-reactive protein was 5.58, homocysteine at 6, so not too bad. However, homocysteine is another really misunderstood marker. What ultimately homocysteine is telling you, or we want it to tell us, how well someone is methylating. If it's high, we know they're not methylating, but if it's low, we can't assume that they're methylating. So the ultimate methyl donor is SAMe. And so we want to test SAMe levels. And Doctors Data has that SAMe test that I find very useful in clinical practice, because many people have normal homocysteine, but they're still not methylating very well. So, and that's due to many different reasons. You can still have MTHFR functioning, but you can be deficient in some proteins, methionine. You could be using up your SAMe quicker than you're replacing it. There's lots of different reasons. She also had a high pH, which may mean that she's actually not dumping her acids. So you want to test your saliva if you're testing pH, not just urine, because a lot of times the pH is elevated in the urine, but it's very acidic and low in the body. And that's usually a kidney issue, and the kidneys aren't dumping the acid. White blood cell esterase was elevated. That usually is a marker of multifocal dysbiosis. So some genitourinary dysbiosis, not a full infection. We do see down here though that she did a clean catch and there was bacteria seen in the urine. So that's an indicator that, yeah, she has, we don't call it an infection unless there's a clinical symptom, typically, just so everyone's on the same page. But it's dysbiosis. There is bacteria there that shouldn't be there. And it's part of what causes the immune dysregulation. And this, again, is what we call multifocal dysbiosis. And oftentimes, this is what is at play when someone has mold sensitivity, is really a multifocal dysbiosis issue, and it's driving up the immune reactions. And as we see, her TSH was undetectable. T4 was, not too bad. A reverse T3. T3 was super high though, right? Here's the ratio. It reflects what she's taking. So you're going to have, if you're going to have T3 at 8.4, and T3 is your active form of thyroid, it's like poison at that level. You're just poisoning the receptors. So it makes sense that she's not feeling really well. This ceruloplasmin is why she was given copper, because it can be a copper indication, low copper, and sure enough, she had low copper, which is important in thyroid function, right? We need copper. The thyroid peroxidase enzyme needs selenium and copper. It also needs molybdenum. So if those trace minerals are not there, then they're not going to be effective at making thyroid. I think her copper and ceruloplasmin was low because she was given so much thyroid that the TPO enzyme downregulated. And when the TPO enzyme downregulates, which is the body's greatest copper need, then the body stops absorbing copper. The body's like, well, we don't need it. There's no TPO. And TPO is the largest store of copper other than the bone. So if there's not a lot of TPO because of this thyroid prescription that was too much, then the thyroid's going to be low, the copper is going to be low. So giving her copper isn't necessarily going to jumpstart her thyroid, but always remember that to check your copper, to check your micro nutrients, to see if that's part of why someone's thyroid is not functioning well. She was taking, in my opinion, too much vitamin D. We see large epidemiological studies showing that for nanograms per milliliter, as it's reported in the U.S., the lowest rate, the nadir of all-cause mortality as it relates to vitamin D is around 40. So I know that flies in the face of what a lot of people say in functional medicine, but the data proves that that all-cause mortality actually starts to go up above 40, long-term, above 40. There are times to supplement with vitamin D in high levels, but typically long-term, you want vitamin D levels around 40 to 45. That's what the research says. And in my classes, I give you all that data. Her vitamin A wasn't bad. Zinc wasn't bad. And keep in mind, these are plasma levels. So not necessarily reflects what's inside the cell. Like I said, these are useful tests, but I don't often rely just solely on this, as you'll see. Magnesium here, also, these are reported values in population, right? And if the whole population is deficient, which they are, I actually think her zinc is a little bit low. I like to see that, at least above 100. I mean, it's not too low, but even 150 is fine, and because the whole population is low. So her let's see what else. Her magnesium red blood cell, also we want that above a 6. So her magnesium is a little bit low as well, even though it looks like it's right in the middle of the population range, not necessarily healthy. Her vitamin B6 is okay, but it may not be sufficient for her. The range is 3.4 to 65. Again, this is a population that's relatively deficient in B6, so I like to see it above a 50. So she's not likely to be experiencing overt B6 deficiency symptoms, but it's certainly not optimal, and it's part of the methylation cycle. It's critical, and it's critical in glutathione production because B6 is the rate-limiting vitamin in cystathionine synthase, right? And that, or cystathionine beta synthase, or the CBS gene. So you're not going to make glutathione if you don't have enough of the B6. So that's there's another test that I run, and this is a micronutrient test. This is looking at how cells actually respond to a nutrient. So she was taking a lot of supplements, but look, she was not taking a good B complex. And so all of her B vitamins showed as a significant need. You don't want to be anywhere near the yellow or gray bar. Even, really, we want everyone to be more to the top of all the green bars, because that means that cell didn't respond. It didn't respond favorably to more of that nutrient, which means then you're replete. And sure enough, zinc did show up here. Magnesium also showed up here. So showing that those plasma levels don't reflect optimal functional levels necessarily. They're good to look at both. So that's why I like to look at both. And our glutathione levels were okay, but this is just in response to white blood cells. As we'll see, there's other factors that can influence whether or not that glutathione is working in the body. Cysteine is a little bit low. Selenium is a little bit low. Alpha lipoic acid, vitamin C, and chromium, which is part of the insulin receptor, is low too. So we can see right here what we can do immediately in addition to what she's already taking. So we know that she's not going to experience health, no matter how many supplements she was taking. She wasn't getting the right foundation. And without the right foundation, then you're not going to achieve clinical success. So this is the food sensitivity, IgG food sensitivity that I was referring to earlier. This is 240 different foods. And for my testing protocols, you can email me. So email me and I'll give you exactly what tests that I use. I kind of have tier 1, tier 2, and tier 3 tests. What are the tests that I run on everyone? What are the tests that I run on more complex cases? And what are the tests that I run on the most severe of cases? So this, I would say, is about in the middle. These are all of my tier 1 and tier 2 tests. So, but without removing these are foods that are likely driving the interleukin response. And remember, this is a blood test. So these antigens to foods are actually in the blood. So she had some lectins with all the beans and legumes, almonds, It's not important to go through all of these. The one thing I will say about this test is this test does not tell you or tell the patient what you can and should be eating, because it's not giving us blood sugar information. It's not giving us how it feeds the good or bad bacteria in your gut. It's not giving us nutritional value, essential fatty acid, amino acid content, none of that. But it is telling us what foods need to be removed based on these IgG responses. So just because a food is low on a food sensitivity test doesn't mean you can eat it automatically. You still have to use an anti-inflammatory diet principle, okay? So there's just, coffee. She was having coffee every day. A common misconception is that, oh, this test is just telling you what foods you've been eating recently. No, it's telling you what foods you've been eating that you have a response to. Not every food she was eating is on here that's elevated. So, and she's elevated in some foods she hasn't eaten in a long, long time. So yes, what you are eating is certainly going to drive up antibody production if you have a sensitivity to that food, not if it's not if you don't have a sensitivity to that food. It's not going to drive up that antibody response. So, and she was gluten-free, she was gluten-free for many years. So the gluten and gliadin test here is not going to be accurate necessarily, because even in pediatric cases, we know we have to give someone about 5 to 10 grams of gluten every day for 4 weeks in order for this test to be accurate. There's some studies that have done double that, like 20 grams, which is equivalent to maybe 4 or 6 slices of bread for about a week, and you can still get pretty accurate responses. So we know how important the gut, she had many that were elevated. So that's another indicator that she likely has leaky gut. I'm not going to get too into this. This is for other lectures that I do, but just how the gut affects every part of the body, the neuroendocrine system, the gut-brain axis, but the gut-mitochondria axis is something that is absolutely critical in clinical practice. The gut structure, and we're talking joints, how the gut affects joints, the gut immune axis, which we're talking about today, the gut gene axis, how the bacterial genome, as well as the cytokines and interleukins, both affect the phenotype as well as the genotype. Yes, you heard me right. Our gut can actually change our genetic code, not just the epigenetic function. The gut fertility is huge, that axis, and then detoxification. So that's one of the reasons why it's so important. Gastrointestinal changes generate the holobiont, right? The holobiont is everything that the gut is producing, whether it's good or bad for the body. Whether it's short-chain fatty acids or lipopolysaccharides, the holobiont is what we are experiencing. Most people with leaky gut, they are absorbing these DAMPs and PAMPs, and also MAMPs, which is molecular associated. DAMPs are danger-associated molecular patterns. PAMPs are pathogen-associated molecular patterns. These are the things that drive up our antibody responses and our immune responses. So treating the gut microbiome, we'll talk about that. And this is just another schematic of how the gut affects through GABA and the neurotransmitter system, polyamines, serpines, lactosepin, vitamins, short-chain fatty acids. All of these things affect our epithelial, our immune cells, mesenchyme, and neurons. So that's why it's so important. Understanding the holobiont. This is a great study. Understanding the holobiont, how microbial metabolites affect human health and shape the immune system. I still get from medical professionals, this lack of understanding of how the gut affects our immune system. So we're not taught it in school, right? We have to learn it through postgraduate education, and it's starting to be taught in schools, but it's still relatively new. So this stool test that I run, this is the comprehensive stool analysis from doctor's data. We have these bacteria that are, we can almost, I think we're close to this. We can look at somebody's bacteriology, we can look at someone's microbiome, and autoimmune disease has a very distinct fingerprint. We can almost, I think we're getting close. Researchers can almost diagnose without seeing anything about the patient. They can diagnose autoimmune disease just by looking at the microbiome. That's how sort of homogenous it is among people with autoimmune disease. And one of the things that I see almost every time is Klebsiella. In autoimmune disease. I wouldn't say it could ever be pathognomonic for autoimmune, but if you have this certain microbiome pattern, then yes, I think we can almost diagnose autoimmune disease with just doing the microbiome. We see low lactobacillus, low bifidobacter. We see streptococcus, staph. The other almost pathognomonic tests, pathogens or microbes for autoimmune, it would be Pseudomonas is another one that I see often in autoimmune disease. So there, she has it clearly. Doesn't have. We did a parasitology as well. She doesn't have any parasites, so that's great. But in the stool chemistries here, we see her lysozyme is elevated, so that's telling you there is inflammation in the gut, and her short chain fatty acid balance is off. So she may be producing enough short chain fatty acids, although I like to see it above a 12, even a 14. If you get too much higher than that, that can be SIBO. But remember, even SIBO can be producing short chain fatty acids, so she may not be producing enough in the lower intestine. So we can't use this test to say definitively that she doesn't need any short chain fatty acids, but because the propionate is a little bit low, there's an imbalance in her short chain fatty acid percentages. So another indicator of dysbiosis. So because she has Klebsiella, there's something that we're going to need to do for that. So keep all these things in mind. This is another test that I run, just looking at different nutrient elements, and sure enough, it corroborates low copper, low zinc. So she does have some of that. And look down here, she has high mercury. And when you run this is whole blood, we know that it is a short exposure window, usually 72 hours, maybe 7 days. But in order to know what the body burden is, we want to look at the challenge test, a urinary provocative challenge test. But clearly she's getting a lot of mercury. We quizzed her on it. She was eating a lot of tuna. But she had been for a long time. That's part of the environmental triggers. That's part of that third triad of the autoimmune triad that we want to address. So, and her previous practitioners had not done these kinds of tests to really look at what's going on. She was low in vitamin E as well. Her glutathione status wasn't horrible, but I'd sure like to see it much higher. She was getting oxidative lipids, so she was undergoing a lot of oxidative stress at the time. And her essential fatty acids were completely out of balance. This is often what we see when someone's just taking a fish oil. It still blows my mind that practitioners, not so many practitioners, but still practitioners, but a lot of people treating themselves, they're just taking a fish oil, an EPA and DHA. That's almost always going to result in an omega-6 deficiency. And sure enough for her, gamma-linoleic, dihomogamma-linoleic acid, arachidonic, we need a balance of 3s, 6s, and 9s. And so, her EPA was really high, but not sufficient. That's not enough to have a balance in essential fatty acids, and mitochondria is going to suffer for that. And sure enough, we see some other essential fatty acids being out of balance. And we see her mitochondrial organic acids being elevated too. So this is a proof that she does have some mitochondrial issues. I know I'm going through these fast, but I'm giving you an overview of the kinds of tests that we want to run to not guess and to know what's really happening in the body. If you want to know more about these, you can listen to my courses. You can enroll in my nutritional pathology, functional medicine course, or you can take my mentorship course, which I'll give you more information about here at the end. So stay tuned for that. Her detoxification markers were also out of balance. So, and she had some microbial dysbiosis acids as well. So confirming the dysbiosis that we saw in the stool test. Now, if you remember, she also had low sodium serum, relatively low sodium serum. So we want to run an adrenal test. Now, her adrenals weren't horrible, so I give her credit for that, right? At least her adrenals weren't horrible. But here's really a really critical marker that a lot of people miss, and that's this decrease from your morning to your noon. And if you have more than a 50 to 60% drop in that, then that's an indicator of chronic infection, dysbiosis. It's an indicator of some type of chronic disease. So while her adrenal cortisol output was okay, she went from 21 down to 5. So that is an indicator that it's likely not her adrenals. She's got some immune issues, and her DHEA is elevated. So remember, she had some ovarian cysts in her history. So this elevated DHEA is an indicator that, yeah, she likely does have a mild PCOS. So things like N-acetylcysteine and berberine, those are the things that we want to incorporate in our treatment plan. But we're not guessing. We're looking at her hormones, and we know exactly what's going on in order to treat it. I do think that saliva testing is much more accurate for DHEA than blood testing. So, we see more often in PCOS that the saliva DHEA and urinary DHEA is higher than the blood levels. So why that is, it's likely because of what's happening, and it's being sulfated in the liver, and sulfated is DHEA is not as active, and it gets into the tissues a lot quicker. So her melatonin levels weren't horrible, but a little bit low in the evening. And oftentimes what I talk about with melatonin is, there's two ways to use a nutraceutical. There's one way to just fill a deficiency, which, she might be suboptimal in the evening, but her morning and nighttime are okay. So she's producing some, but there are indicators, there are cases, especially in leaky gut, that you can use some supraphysiological amounts. I use only maybe 3 milligrams at the most. I find that sufficient to trigger repair mechanisms in the gut and the antioxidant capacity in the brain. More than that, you can get receptor shutdown. So make the correct diagnosis. Use these tests to get a bigger clinical picture. She has hyperthyroid, actually, but she's thyroid resistant. So she actually has hypothyroid. Dysbiosis, gut inflammation, nutritional insufficiencies, essential fatty acid imbalance, T cell activation, methylation issues, mitochondropathy, PCOS, and detoxification impairment. These are the things that were not really being addressed in her previous treatment plan. So you would see that you would guess that she's not getting better. So I always use this three-legged stool treatment model, because if any one leg is missing or weak, the whole stool is going to fall. Everything that you're doing is going to be relatively ineffective. Doesn't mean you're going to hurt the patient necessarily, but you're not getting them as well as you're wanting them, as they're wanting to get as well. So this professional support leg is the things that we can't do for ourselves. Chiropractic, massage, hyperbaric oxygen, counseling. Needing professionals to help you through. Lifestyle, including exercise and stress reduction and sleep and attending to your spiritual needs and social and relationships and nutrition, which includes both diet and supplementation. So all three legs need to be initiated in order for someone to actually heal. So we got her on my anti-inflammatory diet. And if you're curious about that, you can go to my website. We put her on an exercise plan that worked for her busy schedule and that also worked for her chronic fatigue. So we have to build someone up slowly. We did massage, chiropractic, relaxation response, breathing techniques. She's, started some counseling to work with her stress. We put her in the infrared sauna twice a week and hyperbaric 3 times a week. And these are the supplements. Well, we put her on the anti-inflammatory diet. Again, you can go to my website to look at it. It's not just about diet too, but we want to help with digestion. And these techniques right here are really effective for things like SIBO and dysbiosis. So eating slowly is key. Decreasing your stress, breathing techniques is so important before, during, and after a meal. Breathing is really, really helpful at eliciting enzyme production, eliciting peristalsis and absorption of nutrients, taking enzymes, walking after a meal, avoiding your food sensitivities, not overeating, like in the blue zones. Sahara Hachibu is, eat till you're 80% full and no more, even less than that, exercising regularly. So this is the supplement plan that we put her on in my office. So we reduced immediately her thyroid meds in half. Why did I do that? I let the patient know that there's going to be a period here where she's probably going to feel worse before she feels better. But I didn't get her into this situation where she's taking too much thyroid. In order to return those receptors, the number and sensitivity of those thyroid receptors, you have to reduce the thyroid. There's no other way to do it. Now, you can increase the function of those receptors, the antioxidants that we have here, and the vitamin A and vitamin D, that increases receptor function, but there's no way to make those receptors in their full sensitivity to the thyroid hormone unless you reduce it by half. So we put her on a good, effective multivitamin, a multimineral. You can't put enough minerals into a multivitamin. I'm sorry, but most of practitioners out there aren't prescribing a multimineral as well, and you absolutely need to, especially in her case. And after consulting for thousands of doctors over the years, most doctors still aren't doing that, and it's absolutely critical. We put her on a complete omega-3, 6, 9, some methylation support, some liver support, and acetylcysteine. St. John's for her mood, as she had 5-HIAA. She had a lot of monoamine oxidase activation, so we wanted to decrease that. My third tier test for her would be to do a neurotransmitter test as well. But that neurotransmitter test that we did do shows the 5-HIAA being elevated. That's likely a monoamine oxidase activation. So anti-inflammatories like St. John in the brain are very, very helpful at reducing that breakdown of neurotransmitters. We put her on some dopamine support because that also showed that it was being broken down very quickly. CoQ10 for her mitochondria, mushrooms for her immune balance, curcumin for the inflammation, lipoic acid as an antioxidant and protecting her tissues. Lipoic acid is great for leaky gut. Diindolylmethane for her PCOS and estrogen imbalance, adrenal support, mostly for the morning so it doesn't go down over 50%. Glutamine for the gut, pancreatic support for digestion, hydrochloric acid, a small amount of copper, and ribose, which is great for energy, mitochondria, and especially leaky gut. So we put her on a very balanced and complete. It addressed everything that we saw in the tests. We also did a dysbiosis and parasite. She didn't have a parasite, but dysbiosis, parasite, SIBO. I have similar treatment plan, and it's for 2 months. She does. The patient does 10 days of antimicrobials and then 4 days of high dose probiotic. And we do alternate that 2-week plan for 2 months. And then we retest. And most of the time we see a dramatic difference. This is just another, this is her supplement plan again. So 5 months later, we put her on the plan. She started doing everything and she felt great immediately. Even reducing her thyroid meds, she had about a week where she didn't feel good. Not everybody responds this quickly, but after 5 months, she lost 25 pounds, no more PMS that she had. She had more energy than she had before she was pregnant. Her digestive issues resolved completely, which she was very grateful for. But it wasn't a linear curve. She had lots of ups and downs. She felt amazing after the first 2 weeks. The first 2 weeks were a little bit hard. And then she felt really good. But then she was exposed to mold on a trip. She does have mold sensitivity, and that's reworking the immune system and not just removing all mold exposure long term. But yeah, she got exposed to mold. She went on a trip back east, and it kind of really set her back. She had to stop the dysbiosis protocol, and everything kind of came back. And then we were able to start it again. And her thyroid resistance, although hard to treat, and it can take a full year, she did feel immediately better. And these are her labs after 5 months. Her C-reactive protein went from 5.58 down to 0.19. Her homocysteine was at 6.1, went down to 5, but her SAMe levels are good. Her TSH came back up. That means her thyroid is actually working again. And look at her T3. It went from 8.4 down to 2.8. Now, can we bump that up? Sure. But I want to give, I like to see free T3 at least above a 3, but we can at least give her that support and that stimulation of her thyroid so that it can start working again. Her rheumatoid factor went down to 12.4. Her ESR is still a little bit elevated at 31. We like to see that below a 10, usually below a 5. So there's still some inflammation, but it's only been 5 months. But the fact that these lab markers reversed very quickly and she had a good response, this is what we do on a daily basis. But my whole point in this lecture today is to help the practitioner just give you a few more tools to address these complex cases, to give you a few more ideas of where can I look? How can I put together a more comprehensive and effective treatment plan? So this is sort of my top 10 labs. If you email me, I will email you my tier 1, tier 2, and tier 3 labs. So you can just email me through my website. And I'll give you more information about my mentorship as well. So I do a small group mentorship. I take about 10 to 15 docs through a 6-month intensive program. We meet every other week as a small group, and then we meet individually for an hour every month. And we go through exactly what cases you need, wherever you're stuck, however we can move you into the next level of your functional medicine practice. That's what we do. It's a lot of fun for me. I love it because I get to see exactly where you are as a practitioner and move you forward into just greater effectiveness and greater fun, greater ease in the office. This stuff isn't it's not hard once you really get the hang of this. So that's. We cover a lot of things, which labs to run. We go deep into addressing and analyzing these labs on a deeper level. And of course, I also have my nutritional pathology course. A lot of you have taken that, but that's a 6-module, 80-hour course in nutritional pathology and functional medicine. There's 2 different things. I've got the certification course, and then I've got the mentorship. You can take either one by themselves, but if you choose to take both of them, I'm doing a webinar special. So, so if you purchase them together, I give you $500 off. I'll give you another $500 off the webinar. And I've got some really great sponsors. I've got some nutraceutical companies that sponsor it. I've got lab companies like Doctors Data that sponsor it. So you're going to get about $2,500 worth of supplements and tests, free supplements and free complimentary tests when you sign up. And so you're going to take an almost $6,000 course if you do both of them down to just $1,400. So, but this is only, this is only good for this week. So make sure if you're interested, you call us and we can get you signed up. So thank you, Doctors Data, for supporting my nutritional pathology course and my mentorship. These are what's in all of the modules. We go into laboratory medicine. That's my passion. Test, don't guess. Everything from methylation, autoimmune, gastroenterology from A to Z, endocrinology, mitochondria and energy, cardiovascular. We cover it. We cover it all. And it's all in a very succinct, cohesive functional medicine training program. So, and you get your certificate at the end of it. You can take a test and get your certificate. And this is my contact information here. If you want to give us email us, and if you have any questions, we'll do a follow-up as well after this webinar. So thank you, Doctors Data. Thanks for hanging in there. I know we went over a little bit, but hey, it's a complex case. It's hard to fit into just 60 minutes. So thanks for hanging in there. I'll stay for a few minutes if we've got some questions. I'm sure we do.